So thank you all for coming, and thank you as well for being the educators in your community, because I can't tell you how many patients come into the office and say, oh, my neighbor had melanoma, you operated on them, they told me everything you're going to tell me today. So keep doing that in your community, keep telling everybody everything, because it's a daunting task. I think when you walk into your surgeon's office and we tell you what we are going to do, it's very nerve-wracking for you. So the more you can tell your friends who are going through this, the more helpful it is to everybody involved. So our goals of reconstruction, number one is to get rid of the melanoma. And then there's a secondary portion, which is becoming more and more important because everyone's sticking around a lot longer than they used to because of the great work that our medical oncologists are doing. So we want to make sure that you have function afterwards. If you have a cosmetically sensitive area like an eyelid, we don't want your eyelid watering too much afterwards. We want you to be able to see. If you have melanoma in your hand, we want you to be able to use your hand normally. And that goes forth with everything. Drinking, we want to make sure you can drink out of a cup. So the function is the next step after making sure that the melanoma is gone. And then cosmetics, we want you to be able to look in the mirror every day and not be reminded of the melanoma once you've moved through the recovery process. So I'm going to show some pictures today. That's the only way I can show you how we do this. I've edited everything as much as I possibly can. For Dr. Kluger's sake, there will be no blood. Yeah, so when we think about reconstruction, I already mentioned that we want to make sure we restore function, but as a plastic surgeon, we think about the reconstructive ladder. So we start with simple, which means we just close it as a straight line. That's great. That's a win for everyone. We hide the scar in the best place we can and we move on. The next thing in reconstruction is a skin graft, and then local flaps and distant flaps. So a skin graft is where we shave skin off somewhere and we put it there. And then a flap is where we rotate some skin with the fat attached to keep it just as thick as what we took out and put that in the hole. And that gets more and more complex. Sometimes the simplest thing is not the best, and we'll skip it down the ladder a little bit to get to the more complex thing where that has a little bit more risk, but the benefit is greater. So the standard of care for a long time was to put a skin graft on a melanoma defect. Now, it serves its purpose, it fills the hole, but to us anyways, it seemed to have a contour regularity. It didn't look as good. So a long time ago, and then you can see on the scalp, the hair doesn't grow back. It's not an ideal situation, and it's not our first go-to for reconstruction. So our preference is to avoid grafts if we can. And a long time ago, I think many people here know Dr. Arian. He wrote a paper talking about how we can move tissue from somewhere else and keep it the exact same shape and type that what we took out and replace like with like. And that's our goal when we do reconstruction, is to replace like with like. And he showed that it was safe to do that. We weren't hiding any signs of recurrence. There was no more likelihood that we were going to miss something in the future if we put a flap over it. So since then, that's been our goal of treatment, is to do a flap. So this is the only blood picture I'll show, but I had to show this because it shows a defect which you could put a skin graft into it and fill the hole, but you'd end up with a big divot in there. If you look over here, you can see that this flap from up here, it's a little bit of geometry and it's hard to imagine it. And another flap from down here will rotate it into the defect to fill the hole with tissue that looks just like the shoulder on the other side, but you can see the scars that are there, but it makes a much more aesthetically pleasing result. So, and I blanked out the holes here, but so you can't imagine what's underneath, I promise. So this is called a triple rhomboid flap. I learned this from Dr. Arian as well. We take out the melanoma, and then there's a defect here. So you can imagine if you put a skin graft in there, you're not going to have any hair growth there, and you're going to have a big divot in your head. This is immediately after surgery, putting it back together, and then 2 weeks after surgery, you can see the hair is starting to grow back already. So we try and give the patient a full head of hair again if we can. Again, there's another patient, the same exact case, 2 weeks later, again, showing that the hair is growing back soon after the surgery. On the nose, another cosmetically sensitive area. This is a very large melanoma. You can see that we can use the very thick glabellar skin. Everyone has the little pug up here when they pinch it. That's a nice place to have a donor site. And just, you know, within a month or so after surgery, it's starting to heal in place. And I always tell this, and the patients always hear me saying this: give your scars about a year to heal. They mature over time. The collagen has to cross-link. It's like stacking wood. So when the collagen, which is what we heal with, it stacks itself up like this. And then at about 6 months, the same amount of collagen is there, but it starts to cross-link. So if you go from something like this and you cross-link, it gets thinner. And your scar will continue to do that over the course of a year and a half. So that's where the massage comes in, the silicone sheets. If you've been my patient, you know that I'm talking about that all the time after surgery. This is called a VY flap. So right here you have this melanoma that's excised. You move this flap from down here into the hole. At first it doesn't look very good, but I can tell you at a year, the flap is pretty well hidden in the creases and it looks much better. Again, this is the rhomboid flap, which can fill a very large defect. Again, this is the resection that we have to take off, and then we're taking skin from somewhere else, rotating it into the hole, and again, the flap settles over time. And this is just another example of another cheek melanoma, cosmetically sensitive area with a flap rotated into it. And then we do, this is actually one of Dr. Arian's patients. He wrote a paper about it, taking a skin from way down here in the neck. You can see down here, he took the skin from here, tunneled it underneath the cheek, and then had it pop out up here to fill the hole that was created by this resection. So the foot, this is the probably the hardest place to operate on for the melanoma surgeons, because it's a, you want to walk on it as soon as possible. We want to give them function, but they have to have a durable foot. So this is called another type of flap where it went up into the toes, all on the bottom of the foot. You take the flap from down here. I can't show you what happens in between. That's trade secrets, but you put the flap into here to make it heal, and then the flap is pretty well inset. This is about probably 2 months after surgery. These take a while to heal. But the goal here in the foot is not to you try and avoid a skin graft on the bottom of the foot if you can, because it's not like with like. It's not thick tissue. So you want to replace it with something from in the foot already. So you can do these rotations and advancement flaps to fill the tissue so that the patient can walk again. This is right after surgery. I think this is actually in the operating room. Here's a melanoma of the heel. And then you rotate this flap from here and then put that into the heel. And then you can put a skin graft where that came from, because that's the arch of the foot. And that doesn't require, you can have that, have a skin graft that's nice and thin. They can still walk on that area because it's off the ground. So mostly it's just geometry. The ear is another cosmetically sensitive area. You want to make sure the patient can wear their glasses afterwards. This is sort of a traditional way of doing this, is just cutting it out. We don't think this looks very good, so our goal is to try and reconstruct it to make the ear just a little bit smaller, but make it look like the other ear. So I'll give you an example here. So here's an ear with a melanoma right up here in the helix. We call this portion of the ear is the helix. We have to take a 1 centimeter margin of normal skin around this. So it's about this much on this side, this much on this side. So you can imagine if you took it out, you'd look a little bit like Evander Holyfield. So the goal is to put it back together by rotating skin from nearby. Now this ear here, you can see this is the ear that was operated on with the reconstruction, and this is the opposite side ear. You can see that this ear is about 1/4 of the size of this ear. But when you look at the patient front on, you can see that it's very difficult to see both ears at the same time. Even from the back, it's difficult to see them at the same time. So we kind of play on that and just make it a little bit smaller and hope that people aren't trying to look back and forth at the ear at the same time. So here's another example, a wedge out of the top. Can't tell you what's underneath. And then again, doing this advancement flap. So you make an incision all the way down the ear, and notice his earlobe is basically gone. So you can rotate this all the way up here. You lose the earlobe because we used all that skin, but when you rotated it up, it got stretched out. But overall, it looks better. It still looks like an ear. So the eye, another difficult area. So this is the melanoma area that has to be taken out. This box is demonstrating about what had to be cut out. So this is showing the defect is underneath it. So what you can do with the eyelid, and you can do this in cosmetic surgery as well, is you have a lot of extra skin everywhere. So you can release the tendon on the eye over here, advance the eyelid across, and then bring some of the eyelid from up top to close that down and fill the defect so that the patient will have a normal lower eyelid, borrowing from excess skin somewhere else on the eyelid. And again, with the eye, the goal is don't impair vision, don't leave them with a watery eye, and then cosmetics after that. So my job was to talk about sentinel node biopsy as well. So when you come into the office, we talk about a few things. We talk about taking your melanoma out. I tell you how we're going to put you back together again. And then I tell you that we need to possibly do a sentinel lymph node biopsy to determine if there's any what we call micrometastases, very small little cells from your melanoma that may have broken off into a lymph node, and it helps us predict what to do next for you. So there's a few concepts in this, but basically it's like a bunch of grapes. Say if your melanoma's on your arm and you're going into your armpit, we want to find out if it's broken off. We get a preoperative lymphoscintigram, and it tells us where the lymph nodes are supposed to be sampled. We inject some blue dye in the operating room with a little radioactive isotope, and then we take the lymph node out. We use this little Geiger counter to help us find it. Beeps the closer we get. It's really simple. So we inject the node, we find the node with using this little Geiger counter here. There's videos, but I won't show that. And then we take it out. And then this is what a lymph node looks like. Everybody always asks me, what does my lymph node look like? It looks like a little fat grape. So now, years ago, this is called a modified radical neck dissection. So we used to take a lot of lymph nodes out of the neck every time you had a positive lymph node. We don't do that as much anymore, but it still can need to happen for various reasons. And we've changed the way we used to do this. This patient had the sternocleidomastoid muscle, which is right here, removed. So we changed the way we did this a long time ago. Dr. Arian came up with a way called the reverse hockey stick incision, where we make the incision way back here in the collar, way down here, and you can see the scar coming across the collarbone, but we leave the sternocleidomastoid muscle. So even when we're doing an oncologic procedure, the goal is still to maintain as much aesthetics as possible and function. So in summary, the goal of melanoma reconstruction, number one, make you free of melanoma, a functional outcome, an aesthetic outcome, and not have to look in the mirror every day and be reminded of the melanoma. So we'll take questions later. Thank you.